All right, everybody. Okay, so people are going to continue trickling in. Hopefully, if you have any issues with the volume or the video, I'll be sharing my screen shortly. Please let me know in the chat. As far as kind of who we have on the call today, this should be everyone in the College of Pharmacy was invited, including faculty, all students from all three classes, staff, and administration. There are a handful of faculty that I've spoken with. It looks like all of them are on this call. And we will kind of be discussing, as we'll see, some of the things that we are seeing in practice currently with the COVID-19 pandemic. I'm going to share my screen with you. This is going to be our agenda for the day. If you have any questions at all, feel free to unmute yourself. If you would like to and are presentable, feel free to put your camera on as well. It is nice to see some familiar faces that we haven't all seen in a while. So please feel free to do that as well. Okay, so actually, all right. So we have some agenda items here that I want to get through, and this is kind of how we'll approach this every day, or every week, I should say. And the way that I want to start off with today is by talking about how this came to be. So with what's been going on, I think one of the things that has been on my mind a lot has been, how are you guys doing? How are all the students doing? What do you guys, I'm sure this is a completely new time for all of us, but especially you guys as you are in your, second, third, or last year of your P2, P3, or P4 year, that it's just really hard to fathom what you guys are going through. And as your faculty, as the people that are putting you through this healthcare journey, it makes a lot of sense for us to give you a lot of this information and tell you what we are seeing, because as much as you guys are learning from us, we're learning so much being in the field right now, and it's pretty it's nothing like I've ever seen in my short career so far. So what we're going to go through today in our agenda is going to kind of give you an introduction to what these are going to be. I'm going to introduce the clinical faculty that are going to be talking about their experiences in practice currently. We're going to go through a roundtable, some questions that I came up with. I think that would be helpful to get an idea of what's going around in practice right now. There are a few studies I want to review of pharmacologic therapy. There are some that we won't get to today, and the hope is week by week we'll get through more and more as studies come out. We have some student questions, so thank you to those who sent some in through Qualtrics. We'll do this again on a week by week basis. We'll address your questions that you guys have with COVID-19 and hopefully be able to answer the majority of them. If you don't get your question answered today, not a problem. Either shoot me an email or we'll follow up with this next week. If we have time, we'll go to an open forum and then we will close. All right. So let us talk about what the heck are these things. So this idea came to mind from me a handful of weeks ago. Hopefully, we've heard of what a fireside chat is. So briefly, Franklin Delano Roosevelt during World War II did these radio talks to the United States in order to kind of quell fears about what has been going on and the different policies he's implementing during World War II. So these have anything to do from the economy, political moves, things with war, when Pearl Harbor attacked, things like that. And when all of these, the purpose of these were to kind of give the audience and give the country a state of peace and calm, and at the very least, understanding of kind of what's going on. And this is certainly not to the extent as FDR, but this is the spirit of that is why we are doing this. And the Roosevelt name, having the same guy, it kind of works, even though it was Eleanor did that. Anyway, so the purpose of this, the fireside chats, the COVID fireside chats, is to develop a sense of community within our college, to provide support to everyone who is on this call, students, faculty, administration, and to do a few other things for you guys. So hopefully we're here to alleviate any fears you guys are experiencing, any anxiety, loneliness, depression, financial burden, anything like that. Anything we can do to help you guys out, anything you guys can do to reach out to us, we are here for you, and we are kind of your support system, especially at a time where it seems like, there's so much despair. Other things that we are planning on doing is to debunk misinformation that you may be seeing in the media and to provide factual information to our learners. So you guys are probably seeing a lot of this other stuff that, is this true? Is this not true? I got some really good questions that we will talk about in terms of clinical data and what is factual and what's not, because that is a really important part of combating this pandemic, is to give the right information out here. Relay firsthand experience with how clinical pharmacists seeing patients in their hospitals are dealing with COVID-19. So a lot of you, or a handful of you, are going to be doing residencies in a few months, and a lot of you in the next few years, you're going to be out in practice, and you're going to be seeing patients like this, and you're going to have to know how to deal with this. The last month or so, or even longer than that, several months, has been a complete practice transformation for me personally, as well as a lot of my colleagues. And being able to learn how to handle something that you have never handled before, how do you learn that? And I think the best way is through experience and through working with each other. So that's what we're going to try to do. We'll relay our experiences to you and then kind of go from there. Lastly, one of the big things I want to get out of this is to review clinical information. So I've never had to quickly and critically evaluate literature in a way that I am currently doing right now. And it is something that is fascinating. It's very tiring and exhausting, but it's also something that I'm learning a ton every day, and I think a lot of us really are. What we want to do is kind of show how that is translating into practice. So seeing this in the didactic setting is a little bit different, but seeing this from firsthand experience in an unprecedented environment, I think there's no better way to learn that. And that's one of the real reasons I wanted to do something like this. Okay, the format, as you guys are seeing it right now, is going to be a weekly 1-hour virtual discussion. We're doing this from Wednesdays from 1 to 2. If we need to reschedule it, you'll get that on your calendar. We're going to kind of play it by ear week by week, but there will be set topics we will go over and have a roundtable of different faculty. There's a whole bunch of faculty that have different expertise in different areas. This week, I'm going to be focusing on those that are seeing this kind of on the front line, seeing this in their clinical inpatient practices. Throughout the weeks, my hope is to be able to get through different roundtables of different faculty who practice in other settings, community settings, ambulatory care settings, and as well as our basic science faculty, who will provide the foundational basics for how they are approaching treatment, prevention, and overall control of this virus. I think it's also a big public health matter that we need to look into. So from week to week, you guys are going to still have that same Qualtrics link that I gave a couple days ago. So continue to use that link to add questions, and I will compile those week by week. And that way we can either A, take questions from them, and B, discuss different topics. So say I want to learn more about this drug, or I want to learn about this study that I saw in the news, then that can be something that we could take into account and bring that into our discussions every week. All right, and last but not least, your role here, which would be attendees. So tell your friends in the College of Pharmacy. Right now we have 65 participants, which is fantastic. Get more. I want to have this thing maxed out. I want Zoom to be calling us saying you have too many people on this Zoom meeting, but that will be fine, because that's what we want to have. We want to spread information. We want this to be a dynamic environment where you guys can learn and where you guys can really get a better understanding of what's going on. Be curious. Ask questions. So if there's something that piques your curiosity that we are learning today, then ask a question in the Qualtrics for the following week, or shoot me an email. We can do both of those. Do research on your own and participate in presenting your experiences. So I know some of you work in community currently. I know some of you work in hospital. You may be seeing these in different facets than even we're seeing them. And that's something that we want to get those experiences. So again, if you wanted to be on, some sort of panel, you wanted to speak up, we're going to have an open forum, and hopefully you can participate, and we would love to see that. And the last thing is, I want you guys to learn. Like I mentioned, this is completely unprecedented. We haven't seen anything like this since 1917, 1918, and with the flu pandemic back then. But this is the best time to learn about something like this. So it's something that in our careers, hopefully we won't see this for another 100 years, but it is something that at this very moment, there's so much to take away and so much to learn from this. And that's what I hope to get from you guys. All right, excellent. So let us start. So I'm going to sure I could see everybody. Okay, so let us start. I'm going to start by introducing, I think all of the faculty listed here are here. So I'm going to go one by one. I'll start with myself and then we'll go down the line. I'll just have the faculty just introduce themselves, their practice site, and who they are. And if you guys can please keep your videos and your audio on from now on, because we're going to be doing the roundtables, that would be fantastic. All right, so I am Dr. Allegro. I work at Mount Sinai Hospital. I am an infectious disease pharmacist, so this has been, I've expected this would happen sometime in my career. Didn't think it would be this early, but it is something that there are a lot of experiences that I've had so far that I would love to share with you guys and see what I'm learning and going from here. So Dr. Amuo.
Hi everyone, I'm Dr. Amuo. I am also at Mount Sinai Hospital. I recently just joined the faculty, and so it's kind of an interesting time to come in a new position and having to be flexible with all the different changes that we've implemented. But thank you guys for joining today.
All right, Dr. Bartosik.
You're muted.
Yeah, you're muted.
Let me unmute you real quick. Oh.
Okay,
all right, go for it from the top. Yep.
See, this is all new for all of us. I'm Amanda Bartosik. I am also a recently new pharmacist faculty at Roosevelt. My practice site is at University of Chicago. I work in the internal medicine group, and specifically my services cover a lot of like immunosuppressed patients or patients with solid tumors. But now with COVID, it's been a lot of, we'll talk about it probably a little bit later, but persons under investigation for COVID. So that's what mainly how it's kind of switched over is I'm working with a lot of patients who are being tested and being assessed for COVID.
Great. Dr. Cooper.
Hey everyone, Craig Cooper. I'm in the critical care unit at Northwestern Memorial Hospital. I'm actually in the medical ICU, so we're getting kind of the main meat and bones of these patients. Currently we have 62 patients in our ICUs. We have 4 separate COVID ICU units, and I would say 2 of them are very severe, and then the other 2 are a little bit less severe patients. As Dr. Allegro said, this is completely new to us, but we all saw it coming. We all knew it was coming. It was just a matter of time before we actually faced a pandemic. But I have to say, this is a pandemic on a scale that I did not anticipate. These patients are unbelievably complex, which I'm sure we'll be talking about here in just a second, but definitely an amazing learning time for everyone involved.
Thank you, Dr. Cooper. Dr. Hammadi.
Hi, everyone. Thanks for tuning in today. So my name is Dr. Lena Hammadi. I also do internal medicine at Rush University Medical Center. So Rush is getting slammed very similar to many other hospitals with many COVID patients. We're still seeing a lot of internal medicine patients, but I will say a lot of the patients we're seeing now are also persons under investigation. So the entire, I would say, there's a huge shift in the types of patients that we're seeing. And I definitely didn't expect to, be a healthcare worker during a pandemic this early on in my career. So it's definitely a very different experience, but happy to share what we see today.
Great. And then last but not least, Dr. Majerzik.
Hi guys, I'm Dr. Majerzik. So my practice site is at Loyola Medicine McNeil Hospital. I do a hybrid of internal medicine and then M-Care. And I've been working, at my site every day since this pandemic has kind of, erupted, if you will. And just some updates. We currently at our hospital have, as of yesterday, 11 inpatients that are PUIs, so patients under investigation. We have 37 confirmed inpatient cases, and with about 14 patients that were PUIs that were sent home for isolation that were able to kind of be released and discharged. So we also are dealing with this, just like Dr. Lena Hammadi and everybody else said, frontline, and I'm here trying to do my due diligence to help as much as I can.
All right, thank you, Dr. Majurzik. All right, so a few of you kind of gotten already into the first question here. So now we're going to kind of throw this to a roundtable. So basically, I'll throw out a question, and then whoever can answer and provide any additional feedback, that would be fantastic. For those on the call, if you wanted to ask a question during this time as well, if we can get to it during this section, great. If not, we will save that to open forum or till next week. But toss out any other questions that you guys have in the chat, or if you wanted to unmute your microphone and speak, that'd be great too. All right, so the first question, a few of you have already talked about this, but describe the current state of COVID-19 in your facility and your role in caring for these patients. So I'll start, and then whoever wants to jump in afterwards would be great. So as part of the infectious disease team, I'm on daily COVID calls. So every morning at 10:30 a.m., we talk to, it's a very interdisciplinary thing where we talk to all the attendings in the hospital, those who are taking care of COVID-19 patients. So on the call is those attendings, our infectious disease attendings, and there are a few pharmacists, including myself and our ICU pharmacist. And what we do is we kind of talk about all of our PUIs, or patients under investigation. So those that we are considering are a potential COVID positive patient. So we are testing them, we're waiting their tests to get back, as well as our COVID confirmed patients, how they are doing, disposition, AKA, are they gonna head to the ICU, or are they gonna to step down to the floor, are we gonna discharge them home, or are we gonna send them to Dr. Hammadi's hospital at Rush, because that is where we do send a lot of our sick patients, because we do not have certain treatment modalities at Sinai, unfortunately, that we can use on them. In addition to that, and we'll talk about this a bit later, we decide on who to initiate therapy on as a group. So the only therapy that we have available for our COVID patients is hydroxychloroquine with azithromycin. So we'll talk about that quite a bit later, but that is something that we decide on who we should treat in those patients. So speaking for myself and Dr. Amuwo, we have had a total of, checking right now, we had an update yesterday. We had a total of 260 cases within our health system. So that's Mount Sinai Hospital and Holy Cross Hospital down on the south side, as well as, and this is kind of, it's a bit staggering, but 80 employees / providers that have tested positive for COVID-19 as well. So these continue to increase, and there are a few questions about where we're at in the curve. And it's expected to continue increasing for the next at least week or so. So that's kind of where we're at. Do you have anything to add to that, Dr. Amuwo, from your end of things?
The only thing I wanted to add was it's, as to be expected, going into the field of pharmacy and being flexible was kind of one of my biggest lessons that I had to learn through this. So with our schedules, with the way that the pharmacy is operating now, with a lot of the shortages that have resulted from this. So just being able to keep your eye on every single thing that's going on and read your emails and, making sure that you're staying abreast of the information, which is part of why we're having this session.
Exactly.
I can talk about what's going on at Rush.
Sure.
Okay, so right now, so like I mentioned before, I am an internal medicine pharmacist at Rush. Just to give you guys some numbers as well. and we have a ton. But currently, across the entire Rush system, we've had almost 2,000 positive patients, and we currently have 222 positive COVID patients in our hospitals. So we have a lot. And we'll kind of talk about this a little bit more later, but that's why we have quite a few clinical trials going on with some of the newer medications, but we'll get into that. In terms of how my practice has changed and what we do, so like I mentioned before, some of the focus now is on our persons under investigation, so those that we don't know if they're positive for COVID yet. As of maybe like 3 days ago, our guidelines have actually changed because usually, so if a person's under investigation, usually before you would consider possibly treating them with first-line treatments for COVID, such as like hydroxychloroquine plus or minus azithromycin, and we'll talk about that a little bit later. However, we're seeing that even for persons under investigation, our guidelines have actually shifted, and we're no longer recommending any treatment until we know it's positive. And even then, we're being very strict, and our guidelines have really changed in terms of treatment. And I think we'll touch upon that later, so I'll just hold off on that. But so really everything's changing based on what we're seeing and how many patients we have and the responses that we're seeing to different therapies. So that's really interesting too. And then I also want to talk about just like workplace flexibility as well, because we're seeing a lot of that. We're also trying to put in place some faculty working from home and some faculty working on site. So for my department, for example, we're 6 internal medicine pharmacists. So we try to do 3 working from home every day and 3 on site and just try to switch off. And the reason that we do that is to decrease exposure, obviously to a site that's very high, has many COVID patients. So that's just something that we've been doing. So that's a little bit different too, because I'm very used to rounding obviously in person with the teams, but now we're doing like rounds over the phone when we can. So it's just very different. But the biggest thing is to be flexible and to recognize the bigger picture that we're all health care workers working part of a team and kind of taking care of our patients. So, but it's been different for sure.
Any other folks from the other hospitals?
Yeah, Dr. Legro, I'll chime in.
Yep.
This is Dr. Cooper again. Looking at our numbers, we have a total of just under 1,500 confirmed cases throughout the entire, excuse me, I wasn't a COVID cough, people, relax. 1,500 cases across the entire system. And at our Northwestern location downtown, we've had little over 500 confirmed cases with 13 deaths. So we have a death rate of about just over 2%. Similar to Rush, we are doing a lot of studies right now. We have multiple studies going on with multiple different drugs. A little bit different than Rush though. And I'm not sure how quickly you guys get the turnaround. We actually have the quick test now, so we get our turnaround time is really rapid, thank God. We also have a test that Northwestern developed themselves, which if we ran out of the quick test, we still would get results between 4 to 6 hours after taking the test. So those are some of the improvements that we've made. As far as rounding, like I said, we now have 4 separate COVID ICU units, and that's staffed by our critical care pharmacists as much as possible. Generally, we have 2 ICU pharmacists on every COVID unit. That's how busy those units are. You may say, well, there's only 60 patients. Well, I can tell you 15 COVID patients is a lot per pharmacist. So people taking care of them in the ICU would tell you that's quite a bit. And some of the things that we've really kind of honed in on is early proning of these patients, hopefully keeping them off of vents. That seems to be helping a lot. And I know we'll be talking about this going down the road, but the anticoagulation difficulties and a real concern with healthcare systems across the United States right now is how quickly we're depleting our opioid supply. So those are some of the big concerns that we have. As far as Northwestern specifically, our ICU pharmacists are highly integrated into the teams. One unit, our main COVID unit, we actually are still doing formal rounds, not going in the patient's rooms, but going room to room to room. Again, not going in the rooms. The other ICUs are generally doing what we call table rounds, where we sit down and discuss every single patient with our typical team includes an attending physician, a pulmonary fellow, and one senior resident. So it has to be a senior resident. We are not allowing any interns in the COVID units right now. So they're all senior residents, a pharmacist, the nurse, and the respiratory therapist. So that's kind of the layout at Northwestern, just like everyone else. A lot of flexibility here. We are actually are lucky in that some of our medical floor pharmacists are helping out in the ICUs to give us a little bit of a break, because we're all working extra shifts to try and cover this. Definitely the most probably stressful and taxing thing that I've ever experienced in my career, but also one of the most interesting.
This is Dr. Majerzik again, sorry. Thank you so much, everyone, for sharing your experiences. Some other updates from the healthcare system that I'm in. So it encompasses not only my hospital, but also the Loyola University Medical Center in Maywood, which is the biggest location, as well as Gottlieb. So we have a total of 28 inpatient PUIs, and then total confirmed across the system in terms of inpatients is 127, with 117 that were PUIs that were sent home for isolation. And that's data as of yesterday. In terms of some of the modalities and the structure of what we're doing here, we have gone through and converted into table rounds exclusively, where we have the chief resident actually being gowned and actually seeing the patients, reporting to the attending physician, and the attending physician typically sitting in the library in a separate conference room with all the computers and looking at all the patients' data with a pharmacist, which for this particular service is me. But as Dr. Cooper had mentioned, I think one of the non-pharm measurements that we're seeing is early proning. And that's typically what I see also at our institution, especially with the younger patient population. And then we're trying to use different methods for some of our patients that are obese or morbidly obese. We're finding to see, we're trying to see if proning is better before or after ventilation, and we're trying to hold off with putting our patients on ventilators for as long as possible. And then also in addition to that, we're noticing some, spikes in some inflammatory markers that are really alarming in these patients, such as, ferritin levels skyrocketing, as well as D-dimer levels being in the thousands. So these patients, for some reason, become super hypercoagulable, and then, obviously anticoagulation is my passion. So a lot of anticoagulating, either patients with heparin or low molecular weight heparins, but we're seeing some D-dimers that are even 1,000 times normal levels as well. I think that's all I want to say, because I want to give everyone some opportunity to ask some questions as well, but feel free to ask. Thank you.
And then I can just briefly talk about UChicago for us. So as of yesterday, we had 123 COVID positive patients and 66 PUIs that were in hospital. We had 36 ICU cases of COVID positive, and 9 of those have been vented. We have vented cases. We also had, 146 employees have tested positive. 5 of them have been physicians, 8 are residents, and 28 are nurses, and then 105 are other workers. So not even directly related, in direct contact with the patient, which I think is interesting. We also have been doing a lot of clinical trials with different medications. We've also been using this, which I just recently read about, is this, like, they call it helmet ventilation, to try to preserve any ventilators by not preventing patients from being intubated, and to preserve any ventilators that we have. But right now we're good on ventilators. And as far as my role, again, I'm assessing and taking care of patients who are PUIs. So any patients that come in with signs or symptoms of COVID get immediately put under this PUI pathway. And we start precautions and everything on those patients right away. We've been doing, and I don't know about other hospital health systems, but we've been doing 2 tests per patient. So usually patients who are PUI are in the hospital for 4 to 5 days, because they have to have one test that, a COVID test, and then 2 days later, they have to get another COVID test to make sure that they stay negative. And let's see what else. I think
Dr. Bartosik, are those tests, is that the rapid Abbott test, or are those PCRs?
They're PCRs.
Okay. So what's the turnaround time for those that you're seeing?
They're pretty quick.
Yeah.
The biggest part, yeah, it's within hours, I think 3
Okay.
4 hours. The biggest part is that it has to have 48 hours in between the 2 tests. So the patient has to stay there for that amount of time. So once a patient has 2 negative tests, then they can be, if they're healthy enough, then they can be discharged.
That's really interesting. I haven't, that's one thing that we're struggling with a lot, is disposition. So a lot of our patients that get sick and get COVID are nursing home folks, and a lot of them they turn positive, they do fine, and then they get well enough clinically to go home, and then their test just doesn't turn negative, or how many negative tests do we need, sort of thing. And this is a question I got from the chat here, which was, what is the turnaround time right now that we are seeing? So many of you guys may be aware, and it seems like they're doing that at Northwestern and at UCM. There's a test from Abbott that detects viruses. It isn't necessarily exactly a PCR, to my understanding, but the turnaround time is very quick. Like, you run it on the machine and it should spit out a result in like an hour, and then logistically you could get a result in like 2 hours, reported back to the physician. What we've seen, I don't know if you guys are seeing this at all, but we've seen that although that it was validated, the test itself has poor sensitivity. That is something, I mean, students on the line kind of think back, what does that mean? So if you have a poorly sensitive test, that means you're going to have a higher rate of false negatives. You can't detect true negatives as well. So what that means is, if it turns back negative, you can't necessarily say that this patient doesn't have COVID. To put that another way, someone who presents clinically as COVID, so they have shortness of breath, they are having these elevated ferritin D dimer levels, their chest X-ray is showing, ground glass or the CT scan is showing ground glass opacities, their flu's negative. A lot of times you have to think COVID. Right now, basically 70% of the patients, there was a news report on Sinai a couple of weeks ago, but basically 75% of the patients we're seeing in the ED, those folks are going to be PUIs essentially, because that's just the reality of it right now. And if you get a test back and it's negative in a poorly sensitive test, that negative test doesn't mean anything. If they clinically look like COVID, we're treating them as COVID. If they turn positive, it's a good test, it's fine. The specificity is fine, but the sensitivity of this new Abbott test is not great. So we're doing something similar as Dr. Bartosik is doing. We're sending out confirmatory tests. In addition, if we have a negative rapid test, we send out confirmatory tests, and that comes back in about a day or 2. So I don't know what other folks are seeing. I mean, you go back, you rewind, but for us about 2 weeks ago, our tests were horrible. They took 4 to 5 days to come back, And even then, we couldn't really be sure of the sensitivity and specificity of them. So now it's better in terms of turnaround time, but the sensitivities of the tests are still poor. So what are your guys' kind of thoughts on that?
Hey, Dr. Luger, this is Dr. Cooper again.
Yep.
This is such an important point to make about the sensitivity of the rapid test. And what we're doing at Northwestern frequently is we would do both the rapid test and then we would do our PCR if that person is negative. And to your point, this is why, you know, a basic understanding of statistics is so very important, to understand the difference between sensitivity and specificity. A test like Abbott has developed is fantastic for patients who come back positive. But just because they, you know, but if they get a negative, you can't be for, you know, you can't say that that person is truly negative because of the poor sensitivity of the test. And we don't actually have the numbers yet to tell us the sensitivity and specificity of this test. But in patients who come back negative that look like they're COVID positive, we are then going on and doing our PCR testing, which has a very high sensitivity to help detect whether these patients are truly COVID positive or not. So just because you have a rapid test and you hear in the media, hey, these rapid tests are great, well, always keep in mind, what is the sensitivity and specificity of that test? And if you don't understand sensitivity and specificity, now is a great time to start learning about this, because you'll hear this constantly in the media, and to be able to talk to your family and friends about, hey, you know, just because it's a rapid test and you get results within, essentially within an hour, doesn't mean that it's actually a good test.
All right, fantastic. Yeah.
I had a quick question. This is Lena. Hi, guys. For those that don't know me, I'm a fourth-year student, currently on rotations. I had a question for you guys regarding, since we're on the topic of testing, are your institutions doing like any kind of like serology testing to test for antibodies? And follow-up question to that, have you noticed cases of reinfection? Because I know there's some reports out there of people improving after the COVID infection, but then remaining positive afterwards.
Antibodies, no, we have not done that. Although there are some interesting things kind of going on right now with that. There's studies with convalescent plasma that we're not going to be talking about today, but I think that is a very interesting route to go down, unlike some of the other things that we are currently using in practice. As far as folks that get better then get either reinfected or their infection recurs, it's really tough. We've had in the last like week and a half or so, there's two patients in particular that got better. They were in the ICU, they were intubated, and they got extubated eventually after about a week or so. And then they got sent on a step down. And then we're just kind of like, one of them had multi-organ failure, so that was kind of being managed, getting dialysis as needed, things like that. But then on Monday, between Monday and Tuesday, both these patients actually ended up crashing again, and then they got re-intubated. So their tests have been positive the whole time, but they got better, then they got worse. So I assume that this is not the only case of that, and we are seeing some of this where you even have a negative test and then you turn positive again because of whether it's reinfection or, you know, like you said, the sensitivity of the test is poor, so that might be a false negative, and then they were just positive this whole time. Have you guys seen any of that in your practices?
I just want to chime in about the antibody testing real quick. This is one of the studies that we're actually doing. One thing I want to caution everyone on these antibody tests is we don't actually know if these patients are actually going to be, you know, if you get infected and you have antibodies present, we actually don't know yet, or don't actually have any idea yet if that actually gives you immunity down the road. This is one of the things that's actually being studied and looked at. So that jury is completely out. We're actually doing part of this test at Northwestern, but that jury is way down the road before we actually have any idea as to whether that's going to be effective or not.
This is Dr. Hammadi. We do not currently have the antibody testing at all, so I can't really speak to that. but I can speak to the other tests that we've been doing. So we do have that rapid test, which comes back in about an hour, but we're only doing it in the ED. Otherwise, everyone just gets the regular test that comes back, the regular COVID PCR that comes back in about 8 hours. That's what we've been doing typically. We do sometimes retest patients, but that's only if their first test was negative and we have a really high clinical suspicion that they may actually still be COVID positive. But it was really interesting to hear that U of C does the 2 tests. That's really interesting. We do not do that. We just we check them again if we have like a high clinical suspicion, but the first test was actually negative. But yeah, that's kind of what we're doing.
Students, it's like we are learning what to do on a daily basis. You can't be like, oh, let me go check the peer-reviewed randomized controlled trial COVID guidelines. That's not a thing. And actually, the IDSA did come up with one the other day. But if you read those, they're not that helpful because we don't have that data. So we work with each other and we talk to our colleagues at different sites. I've been talking with Dr. Hammadi and Dr. Cooper a lot, and what are you guys doing? I've talked to some of my residents that are off at different institutions now that, like, what are you guys doing at your hospital? It's kind of, honestly, in a lot of sense, it's your best educated guess, but this is why you guys go through school, and this is why you guys become the best pharmacist you can be, because when we face something you don't know what's going on, then you have to rely on that. So do you have something to add, Dr. Bartosa?
Yeah, I was just going to say that we don't do serology testing either, but it's something that we're looking into. We want to try. And then just like another thing there was a question at one of the town halls that we did at our hospital about workers who are positive and when it's safe for them to come back and if they need to be retested. But again, that's hard to do as well since PCRs can stay positive for a while. So we're trying to get serology testing for that aspect. But then again, going back to Dr. Cooper's point, we don't know with these antibodies what measures, an immune response specifically right now. So that's hard as well. And then another thing that we've been testing for that I'm curious if other people are doing is that if we have patients, even if they're not had the symptoms of COVID, we'll test them before they do any high risk procedures because of this the aerosolized. We want to try to prevent that as much as possible. So I'm just curious if anybody else is doing that as well.
Yeah, this is Lena or Dr. Hammadi, but at Rush, so we are doing it prior to bronchs or bronchoalveolar lavages, because apparently I believe in that it's associated with the highest risk of aerosol spread. So we are definitely testing patients, even if they don't come in with symptoms, to test if they're COVID positive or negative before that. I know that for sure, which is interesting.
Yeah, I don't know exactly all the procedures we do, but we do that for high risk procedures.
Yeah, likewise here at the site as well.
All right, so in typical Dr. Allegro fashion, we are completely running out of time as always. There are things that I have a PowerPoint. I'll send this over to get posted so everyone can kind of look at this. There are several things I'm going to skip over. I'm actually going to pause the roundtable right now because there is a study that I do want to go through. I had 2 studies I wanted to go through. There's one on lopinavir ritonavir, which is Kaletra, an HIV med. I will not go over that, but let me just pull it up here. So this study from New England, this was published, I think, earlier in March. Basically, they found that this is not a great drug to use. It is not very effective for especially severe patients with COVID. So you guys can kind of take a look at that. Maybe we'll get to this in a future talk. But what I do want to get through, and I know a few of us have kind of taken a look at this and are itching to tear this apart, but this is the hydroxychloroquine and azithromycin study that was published earlier in March, I believe. So this was published in France. It was the International Journal of Antimicrobial Agents. And this is the basis for everything that you've seen in the media on hydroxychloroquine and azithromycin being this godsend drug. And this will be a nice review for literature review and how to not conduct a study and publish it. Okay, so we're into the lecture-based portion of this, so don't worry, it'll be over soon. The hydroxychloroquine and azithromycin. This is by Gautreau and colleagues. The reason behind why they studied this in the first place is they found that hydroxychloroquine and chloroquine, for that matter, these are antimalarials. They appear to block viral entry into the cells by inhibiting glycosylation of host receptors, proteolytic processing, and endosomal acidification. So kind of messing with the pH will inhibit virus entry into our host cells. They also have shown to have some immunomodulatory effects through attenuation of cytokine production and inhibition of autophagy and lysosomal activity in host cells. So kind of a few unique mechanisms. So why does a drug that's used for lupus and that's used for malaria effective against coronavirus? This is kind of the background with that. I'll get to another slide in a little bit, but I want to just talk about the study first. It's an open label, non-randomized study that was done in France, and they had a few centers, but this was kind of odd that there was a center in Marseille, and that was the only one that they had patients that received treatment. Other centers in Nice, Avignon, and I don't speak French, Briançon, centers served as the control. And it's kind of unusual. If you have a multi-centered study, it's usually you would have control group and intervention group in all of the sites. So they only had your intervention group in the Marseille Center, so a little unusual. Patients in the hydroxychloroquine group were given 200 milligrams TID times 10 days. We give a different dosing actually in our hospital. We give 400 BID as a loading dose and then 200 BID for 4 additional days. It's a little bit different. And then the primary endpoint was virological clearance at day 6 after they were included into the trial. Okay, so kind of the major methods here. As far as the results, and again, this is the study that launched 1,000 shipments of hydroxychloroquine and azithromycin to everyone, everywhere, okay? So keep that in mind as we talk about this. So about 40% are males, mean age is 45.1 years, and based on symptoms, about 20% were asymptomatic, 61.1% had upper respiratory symptoms. So this includes cough, runny nose, things like that. 22.2% had lower respiratory tract symptoms. So this would be more of your pneumonias. These are the people that really get sick and that have to get sent to the ICU. So only less than a quarter of these folks were actually really quite sick and had lower respiratory tract symptoms. Those are the ones we worry about. Those are the ones that we need treatments now for. If somebody is just presenting with a cough, you're probably gonna get better. You're probably not gonna get intubated, most likely. You're gonna be in the 80 to 85% of people that have mild disease. If you are having lower respiratory tract symptoms and a pneumonia, this becomes more problematic. All right, so here's where it gets a little weird. There's 26 patients that received hydroxychloroquine, 16 were in the control, so they did not receive any treatment. 6 people in these 26 in the hydroxychloroquine were lost to follow-up because if you recall, the primary outcome is going to be virologic clearance at day 6. So if you can't evaluate the patient at day 6, you can't put them in your analysis. So 3 of them were transferred to the ICU. All of these were PCR positive prior to transfer. 1 patient didn't tolerate due to nausea, PCR positive. 1 left the hospital and 1 died. And those latter were PCR negative. Based on this, it seems like those are 5 failures that they did not add to their analysis. Okay, so that in itself is already going to increase our denominator of patients that failed if they were included into that study. So 4 of them were positive for the virus before transferring or whatnot, and then 1 of them died. And even though they were PCR negative, then their initial presentation was with COVID, so they kind of chalked that up to a potential death from COVID, but they didn't analyze them. So you go down to 20 patients in the hydroxychloroquine group and 16, all right? So that's kind of the first big thing with this study. What they found was that virologic clearance was occurred in 14 out of 20 in the hydroxychloroquine group versus 2 out of 16 in the control group. So 70% versus 12.5%. They found that to be statistically significant. The other thing that they found was that in patients that they actually treated, this is coincidentally, patients that they treated with azithromycin to prevent a bacterial superinfection, 6 out of 6 of them, 100% of them, resulted in a numerically superior viral clearance at 100% versus 57%. So 6 patients made so many hospitals across the world use this combination, even though that there are some toxicities that we do worry about with them. I mean, I'm saying that, and at Sinai, that is part of our protocol. I've been trying to kind of push the envelope towards not using azithro, and even kind of being very, very cautious with using hydroxychloroquine, but it's kind of hard to do that. So the numbers here are so small. 6 patients receive this combination. The whole thing about using azithro to prevent bacterial superinfection, that's a whole nother story. I could rant about that during all of my other things I rant about, but that was just a little unusual finding that they found. If you dig a little bit deeper into the study, so this is kind of the chart that they showed, and if you look at that, wow, green, hydroxychloroquine, azithromycin, look at day 5, everyone is 0%. Again, 6 patients, 6 people. So a lot of issues with random error that could have just happened since we have such a small trial. So study looks great, right? So I just want to share a few quotes. This is directly from the study. For ethical reasons, and because our first results are so significant and evident, we decide to share our findings with the medical community, given the urgent need for an effective drug against SARS-CoV-2, COVID-19, in the current pandemic. We therefore recommend that COVID-19 patients be treated with hydroxychloroquine and azithromycin to cure their infection and to limit the transmission of the virus to other people in order to curb the spread of COVID-19. And they do acknowledge this, despite the small study sample, it is associated with a decrease in viral load, especially if you give azithromycin. So these are their conclusions from this study. Doing a little bit of the analysis of the study itself, and then I'm going to open up to my colleagues here and their thoughts on this. I figured it was a small sample size, of course. The removal of 6 patients that we already talked about, 5 of which who most likely would have been deemed a failure, which would have really, really significantly decreased the amount of patients that did well with hydroxychloroquine. This was something that was interesting. I can't say that I can take credit for this. There was a gentleman on ID Twitter who kind of peeled apart this study and did a fantastic job at doing that. Dr. Poget at the University of Michigan. He took a look at one of the graphs they had on there, had something called a cycle threshold. A cycle threshold is essentially how many times do you have to run the patient's sample through the PCR in order to get a positive. So basically, if you have a low cycle threshold, so say you have to only run it 1 time, you get a positive, that means you have a heck of a lot of virus in there because you don't have to run it that many times. If you have to run it multiple times, that means that you're really trying to grab at straws and see if there's any virus there. So you have to run your PCR a lot of times. So if you think of a low cycle threshold as being somebody with a high amount of virus and look at eradication rates based on that, you'll see that in patients who had a lot of virus, hydroxychloroquine, again, low numbers, but only 20% of them did well. They had eradication. In patients with a higher cycle threshold, meaning that they were less severe disease, then hydroxychloroquine fared better. And notably, every single patient that had azithromycin on board had a high cycle threshold of greater than 24. So we're seeing that the people that were successful didn't really have that bad disease in the first place. So that is something that, again, the article that launched 1,000 shipments of hydroxychloroquine and azithromycin, this is kind of where that's coming from. Interestingly enough, there were no clinical or safety outcomes reported. Kind of a problem. That's kind of one of the biggest things we're dealing with at least my side. We see that QTc prolongation, especially with this combination therapy, is a major issue. So it's something that we need to be very careful about and discontinue therapy because, as we're seeing, it's not very compelling as far as efficacy goes. All right, so that's the hydroxyazithro study. Any colleagues want to kind of add to that or give us their thoughts on this study and how you're using this combination or just hydroxy on its own at your site?
Hey, Dr. Lugger, this is Dr. Cooper. I want to chime in on this study real quick. Definitely a study of very poor design. So any of the students that are listening right now, one of the things that's always important to do is to account for all patients. And this study was so small, you take 6 patients out of this study, it radically alters your results and instantly should have thrown this study into the questionable category. For those of you that are familiar with the vaccine and autism study, this is almost the same type of study quality. The researchers were essentially picking and choosing who went into the actual results. Really, really poor study design. And the fact that it even got published is questionable right now. And what's going to be interesting is to watch down the road whether this actually gets retracted. Matter of fact, just today, there was a French study that was much larger. The results of that study were released today that shows hydroxychloroquine has no real benefit in this patient population. Much larger study. I haven't actually read the whole study yet, so I don't know how good the study design is, but you're already seeing a much larger study of what looks like better design on paper, already questioning the results of this study. So don't read what the media tells you. Make sure you actually read the study itself and draw your own conclusions.
I can speak to what I kind of talked about this already. This is Dr. Hammadi. What we're doing at Rush. So we're definitely not using azithromycin at all. And even hydroxychloroquine, we're really based on us, first of all, not seeing any improvement in the patients that we've used it before, but even previous studies and whatever it is, it really hasn't shown that hydroxychloroquine has been, we don't know if it's actually beneficial in this patient population. So it'll be interesting to read that study that Dr. Cooper was referring to. So hydroxychloroquine, we're barely ever using it unless the patient's in the ICU. We may potentially give it if the patient has severe enough disease. And that's in addition to remdesivir, which is, we won't have time to really talk much about that today, but one of the clinical trials that we're doing involves this study drug. So we're really not using it at all based on the poor data and the poor outcomes in this patient population. So, yeah.
Yeah, I would hope to decrease our use eventually. Start getting there. Okay, we have a couple minutes left. I'm glad that the discussion is fantastic, and you guys are popping up in the Zoom chat right now. So there are things I'll address. What we can do is I'll kind of take these questions and compile them, and we can kind of have a rolling maybe FAQ list, and then we can answer these as we go. I'm sure even more questions will come up. The last couple of things, I just want to address some of the questions that we got this past week, the last couple of days here. So one student asked, what is the recovery rate of COVID-19 in the United States? So there's this nice little chart here. Let me actually pull it up with updated data. I'll put this in the PowerPoint so you guys can see this. So this shows, this is from Hopkins. You're seeing that a total of 3 million people have been tested in the United States. You can kind of parse out the deaths here and the total confirmed cases. So you can go through all of that data. And then when you get to the actual numbers, bring this up again. So when you get to the numbers in the United States, so of the 611,000 cases as of yesterday, about 47,000 have recovered. So that is our recovery rate there. It's less than 10% at this point. A lot of folks are just currently sick in the hospital with this, so that is a big reason why. And there were 26,000 deaths as of yesterday in the US. Another question, so we've kind of talked a little bit about this. Anecdotally, I haven't really been seeing that much benefit with hydroxy and azithro, but that is not something that that we have particularly studied quite yet, but anecdotally, we are not really seeing that. I don't know if you guys are not seeing that as well. This is a question I think I want to have a talk that Dr. Cooper will help me out on in critical care of these patients. I think I've learned so much about critical care in the last 2 weeks, more than I did during my entire residencies. So it's something that I think there's a lot to be said about that. We touched on proning. I think talking about ARDS, which is kind of one of the biggest complications of COVID-19, down the road will be helpful. I do have some stuff on steroids. A student asks what the role of steroids is in COVID-19. You can read all of this. Bottom line is more harm than good. There hasn't shown to be a proven benefit, and there's a lot of harm associated. Not specifically we've seen with this current virus, but with a big one with flu. They did a big meta-analysis with flu. They did a handful of observational studies with previous coronaviruses, so SARS and MERS. So that showed that you had increased risk of things like of hyperglycemia, psychosis, and avascular necrosis, which we see with steroids, as well as a decreased viral clearance, because we know that can suppress the immune system. Big overall arching point, the SCCM, IDSA, and CDC recommend against steroids, and that should not be done routinely. And last but not least, and I'll leave you guys with a little bit of hopefully optimism. Have you seen a flattening of the curve? Is there hope that this will be over soon? This is the ideal thing we want, right? We want this gray curve here, not the pink one. The scary thing is if you look at where we're at right now in terms of number of total cumulative confirmed cases, that just continues to rise. And I don't think that this is anything that is news, because we're expected to hit our peak around this week, and the hope that this is going to go down in the next few days, within the next week. What is a little bit more nice is that the percentage increase per case, the new case percentage increase is going down. Keep in mind that that doesn't necessarily mean the total number is going down, because the more cases you have, then you need a lower number you need a higher number to get a higher percentage. But overall, it looks like we are on hopefully a decline. Who knows what happens when physical distancing requirements go down, but that is something that we will kind of have to see. All right, so again, as in typical fashion, I am over time, but I thought that was really helpful. If you guys had additional questions, I'll take everything that was said in the chat. I'll write those down. The Qualtrics account, the Qualtrics link for students, if you guys want to add more questions on there, that would be fantastic. Other than that, does anyone else have any questions before we leave, or any thoughts on these chats? All right, great. So to the folks that helped me out today, thank you guys for coming. We will bring this back to you every Wednesday as long as this continues to be an issue. So thank you all for coming. I hope you all stay safe, wash your hands, don't touch your face. I know I did that like 100 times during this thing, but be safe out there. We'll see you guys next week.
Thank you, everyone. Stay safe.